through. There we go.
Welcome, everyone. This is the breakout session on telehealth. So it looks like we have about 10 participants. I think we'll just give it a few more minutes or a couple more minutes and see, give people a little bit more time to sign in, and then we'll go ahead and get started.
Hi, Sarah. This is Gabriella, the Spanish interpreter.
Oh, great.
Yes. Okay, great. Now I'm seeing the instructions. That was my question. Thank you.
Oh, great. Yeah, thank you so much for joining us. Okay, if you're just joining, I think we'll just give it maybe like 1 more minute and then we'll go ahead and get started. Just want to make sure people have enough time to transition over from their break. Okay, welcome everyone. I think we'll go ahead and get started. So this is the breakout session panel discussion on telehealth for children and youth with special health care needs and disabilities. And so to get us started, I just wanted to quickly go over the objectives for this session, which are to provide attendees with an overview of telehealth for children and youth with special health care needs, to discuss gaps and policy initiatives to address those gaps, and to provide specific action items for attendees and ways to relate these to your personal experiences. First I'll introduce myself before I go into a definition of telehealth. So my name is Sarah Leff. I'm with the California Department of Public Health, Maternal, Child, and Adolescent Health Division. I'm the Title V Director for Children and Youth with Special Health Care Needs here in California, and I'm going to be moderating our panel today. And so I will introduce our speakers in just a moment, but before doing that, I just wanted to kind of quickly get us all on the same page. I think everyone is probably very familiar with the term telehealth, but just to kind of provide a standard definition. So this is the definition that comes from the US Department of Health and Human Services, which is that telehealth, which is also sometimes called telemedicine, lets your healthcare provider care for you without an in-person office visit. It is done primarily online with internet access on your computer, tablet, or smartphone. And it gives you several different options for care, including to talk to your healthcare provider live, to send and receive messages, and even to use remote monitoring so that your healthcare provider can check on you at home. Okay, so with that said, I'm just quickly looking at the chat to see if there are any questions. Okay, great, not yet. So I'm going to go ahead and introduce our speakers. So we have Gabriella Barbosa from the Children's Partnership, Dena Davis, who is a parent advocate, Dr. Stephanie Crossen with UC Davis, and Michael Freeman from the Department of Healthcare Services. And so I think we'll just go ahead and dive right into the panel presentation so that we have plenty of time for questions and discussion at the end. So I'm going to first turn it over to you, Dena.
Hi, everybody.
While my slides are coming up, I'll introduce myself. Thank you so much for having me today. My name is Dena Davis, and I'm here with my son, Benjamin. I'm a proud Family Voices of California Project Leadership graduate and serve on a variety of healthcare and special education committees locally in Santa Barbara and at the state level. I'm happy to be part of this panel and share our family's experience with telehealth. Here it comes. There we are. Next slide. So Benjamin gave me permission to share his story. This is my son, Benjamin. He's 17 years old. He loves school, friends, family, horses, sheep, freeways, road trips, YouTube videos, movies, FaceTime, and festivals. He has a rare genetic syndrome called Cornelia de Lange syndrome, as well as autism and ADHD. He's a multimodal communicator using the TD Snap application on his iPad, a few signs and spoken words, gestures, and his smile. He wears ankle braces and used a walker to get around until he walked independently at 10 years old. Next slide, please. So many doctors, specialists, and therapists have kept Benjamin healthy and making progress over the years. We see some of these people on this slide annually and some multiple times a year. And before the pandemic, we saw all of them in person. Next slide, please. Distance learning. When schools closed in 2020, Benjamin was so confused and upset. He loves people and he needs connection. He was over the moon when he could see his teachers and friends on Zoom. Next slide, please. Oh, I don't know. Okay. I dreaded in-person appointments, doctor's appointments for Benjamin before he was fully vaccinated. This was taken at a visit to his ENT. He never did tolerate a mask. I was so grateful for the telehealth option when it came along. Next slide. We had so much fun working on life skills like doing laundry for our OT sessions during the pandemic, or I should say the height of the pandemic, that we decided to stick with telehealth for OT. It reminded me of the early intervention days in Maine where Benjamin was born, with therapy sessions taking place in the home environment. After doing PT and APE with school via Zoom as Benjamin's assistant for over a year, I'm sure many parents can relate to that, we were very happy to get back to in-person PT at our medical therapy unit clinic. During the pandemic, one of Benjamin's behavior therapists moved away. We were so happy to continue sessions and our relationship via Zoom, and are so fortunate to be able to work remotely with this therapist to this day. After pandemic days, when the ABA supervisor had a baby, telehealth sessions allowed us to stay connected with her and gave her the flexibility she needed. So now, benefits and challenges. We continue to work with a few doctors via telehealth for some appointments. For quick check-ins about ADHD medications and dosage changes, telehealth has been convenient. We had several telehealth appointments with Benjamin's gastroenterologist during the pandemic for check-ins about GERD, constipation, and weight. we are back to in-person visits. We check in with the geneticist in LA via telehealth annually after seeing him in person for our initial visit. This worked out great this last appointment as Benjamin was sick and we would have had to reschedule an in-person appointment. We will see the psychiatrist who prescribed ADHD medications in person in April, and will continue short monthly check-ins via telehealth for updates. We continue to see the other specialists in person. Telehealth has been a welcome backup option for ABA sessions when Benjamin or his in-person therapist have a cold but are still up for a visit. And so you can see here on this slide, I mentioned a lot of those benefits, saving money on gas, definitely the flexibility with our schedules. If our providers are running late, I can get dishes done. The challenges have been internet stability, both at the provider's office and at home, moving the computer around for our occupational therapy sessions. And I said, there are fewer distractions with telehealth, but there are also more distractions with some of the unique distractions where we live. Next slide. We are grateful for the connection that telehealth provides. Whether he's connecting with ABA therapists every week via telehealth, going to therapeutic writing lessons, or enjoying music and a few fries out in the community, Benjamin and I are grateful for all the options to connect with those who provide him with care. Thank you.
Sorry, it took me a minute to find my unmute button. So I'm going to go ahead and pass the mic, so to speak, over to Michael Freeman with the Department of Healthcare Services.
Hi, everyone. Can you see the PowerPoint?
We can see it, but we're seeing the view that has the notes, the next slide graphic.
How about that?
Yes.
Okay. That look good?
Yep, that looks good.
Okay, thanks so much. Let me just getting all set up. So hi, everyone. My name is Michael Freeman, and I'm Assistant Deputy Director in Healthcare Benefits and Eligibility at the Department of Healthcare Services. And our team created the telehealth policy for our Medi-Cal members. And I'm gonna walk through that and just share what we've been doing recently related to telehealth and how we're gonna continue these policies going forward. So before the public health emergency, there was still some telehealth utilization across the state, but this really changed drastically once the public health emergency and the COVID-19 pandemic began. DHCS immediately took action and implemented several flexibilities to ensure telehealth was available. And now we're looking at how we can move forward and what we will do on a more permanent basis as we're seeing the state public health emergency end and the federal public health emergency also ending soon. Just to illustrate what has occurred, at the very bottom of the graphic, there's a dark blue line that shows our 2019 data on telehealth utilization. And you can see this is per 100,000 people, but we were in the 300 range. And as soon as the pandemic hit, by April of 2020, we were over 12,000. So a huge jump. And that is now maintaining somewhere around 7,000 telehealth claims per 100,000 individuals. So there's quite a bit of utilization, and we know it's critical for this service to be available. Okay, so we talked about a definition before, so here's another definition of telehealth, and we have, these are kind of cornerstones of our policy. So the standard of care has to be the same, whether the patient is seen in person or through telehealth. This is critical. We want to ensure the services are at the same level no matter how they're being delivered. And in that vein, telehealth is not a distinct service, but it's a delivery mechanism. So it's just one way to deliver services, in person or telehealth. So here's some of the key activities that we've taken and the documents that we've published for the DHCS telework policy. I'm going to go into greater detail on several of these, including the advisory group, the policy paper, and the research and evaluation plan. But all of these documents are available on the DHCS telehealth website, and they can be accessed at any time. So I'll start off with the telehealth advisory work group. So AB 133 had the department creating an advisory group on telehealth. And this group had more than 30 members from a very wide range of stakeholders. We had, just to name a few, Disability Rights of California, Insure the Uninsured Project, the National Health Law Program, California Children's Trust, California Primary Care Association, and many, many more. This work group met several times at the end of 2021 and then also into 2022 to help inform our policies, review our data, provide insights, and discuss our future with our research and evaluation objectives. This work group was critical in informing DHCS on the most effective telehealth policies, what would be most important to communities across California, and how to create an evaluation of these services that would inform our future use of telehealth. And one of the most critical deliverables from this work group was establishing our guiding principles for our telehealth policies. So here are our 7 guiding principles for the policies that we developed during the public health emergency and those that will be continuing moving forward. So first of all, we have equity, which is really that focus on improving equitable access to providers and addressing inequities and disparities in care to all of our members. We have access, which is leveraging these telehealth modalities as a means to expand access to culturally responsive, patient-centered, equitable healthcare, and to strengthen patient access care standards, like our network adequacy. Confidentiality, also critical, patients also need to be informed about they need to provide informed consent just to make sure exactly what is being provided to them. And I'll also go over the model patient consent language in a little bit. And patient choice. So patients in conjunction with their providers should be offered their choice of service delivery mode, whether that's by telehealth or in-person care. We also have the standard of care requirements, which should apply to all services and information provided by telehealth, which includes utilization, quality, costs, medical necessity, and clinical appropriateness. Stewardship, 6.1, is exercising responsible stewardship of our public resources and mitigating and addressing any fraud, waste, or abuse of the service. And then lastly, we have payment appropriateness. And this guides DHCS to consider reimbursement in the context of methods of reimbursement, nature of services, type of care providers, and the health system payment policies and goals. So next I'll go over a few of our key telehealth policies and how they will be continuing going forward. So all of these policies are published in our DHCS telehealth policy paper, which, like I mentioned, can be accessed on our DHCS website. The paper is a great reference document. It has the current state during the public health emergency, our final approach moving forward, and some rationale for those approaches. And just before I talk through these, I want to mention a couple other definitions that may be new to some. Synchronous interaction, first of all, this is a real-time interaction between a patient and a healthcare provider located at a distant site. There's audio-only synchronous interaction, which is solely by audio, like a telephone call. And then there's video synchronous interactions, which are through like an interactive technology platform that has audio and visual capabilities. And then we also talk about asynchronous. Two primary asynchronous formats are store and forward, which is the transmission of a patient's medical information from one site to a healthcare provider at a different site, but without the presence of the patient. And then similarly, e-consults are also asynchronous health record consultation services. So that would be an assessment or management service in which the patient's healthcare practitioner requests an opinion or treatment advice from another healthcare practitioner. So now going to the policies. So the first one, which is really huge, just providers can render all of our Medi-Cal covered services that can be appropriately provided by telehealth modalities, as long as they're meeting the requirements of the billing code. So this is broad-based coverage of all Medi-Cal services that can be provided by telehealth. Also, broadly here, we have asynchronous, like the store and forward and e-consults that I just mentioned. Audio only and video telehealth is generally covered across multiple delivery systems, including our behavioral health systems, specialty and non-specialty, physical health and dental as well. And this will continue after the public health emergency. We also have payment parity between our telehealth and in-person services. So as long as the services meet the standard of care and billing code requirements that apply to in-person services, then the payment for those services will be the same. And just a few more I'll mention. So our FQHCs and rural health clinics are reimbursed at the prospective payment system rate, or PPS rate, for synchronous video, synchronous audio only, as well as store and forward. And critically, they're not subject to site limitations for either the patient or provider, which historically have been in place. And this will also continue after the public health emergency. Providers may also use synchronous video to establish new patients. So audio only synchronous is allowed, but only when the visit is related to sensitive services as defined in our civil code, when the patient requests audio only modalities, or if the patient attests that they don't have access to video. Telehealth is also allowed by some of our newest unlicensed practitioner types like doulas and community health workers. And then just one other thing I'll mention is we're working on some of the, creating a new modifier so we can track the data related specifically to telehealth and the different types of telehealth, including audio only. So next is our research and evaluation approach. We recently published the research and evaluation plan on telehealth on our website. This was published in December. And we really recognize the importance of not just having these policies, but evaluating and publishing the data. And we're really working on making this data fully available to stakeholders. And we're doing that through three primary mechanisms, which you can see on the screen. So first of all, the biannual report. We plan to release this biannual report to address several critical research questions, like what are the most common services delivered by telehealth? What is the volume of telehealth versus in-person visits, and how is it changing over time? And compared to in-person visits, how does telehealth utilization vary across enrollee populations? We also are working on our telehealth dashboard that we're hoping to publish this summer. This would make program data and reports available on our many programs, and this will be fully public facing, and we're looking to be able to filter and stratify our data by modality like synchronous or asynchronous, demographics like age, race, ethnicity, language spoken, and geography. Also service type, whether it's behavioral health, dental, or outpatient medical care, for example. And then also impact on equity and access to services. So again, this summer, we're looking at the end of the summer, hopefully in August is when we're hoping to publish that data dashboard. And then lastly, we have an agency-wide data portal that we will be placing this data as well. And that's more raw data that people can download and do their own analysis as well. So for patient consent, we've also published this sample patient consent on our website. A healthcare provider has to inform their patient at least once prior to the initial delivery of telehealth services about the use of telehealth, and then also obtain a verbal or written consent from the patient. The use of telehealth is an acceptable mode of delivering healthcare services. So it has the patient's right to the services, the voluntary nature of the consent, the availability of transportation to access in-person services when other resources have been exhausted. And then if there's any limitations or risks about receiving services by telehealth. We also have included the notification of a patient's right to make complaints about the offer of telehealth services in lieu of patient care or about the quality of care. And then just looking forward, no sooner than January 1st, 2024, we have 2 additional policies that we're working towards implementing. And you can see on the screen, one is patient choice of telehealth modality. So this means if audio only is offered, then also video has to be offered. And this, again, we're working to January 1st, 2024. And then also the right to in-person services. So there will not be telehealth only providers. This will be that if telehealth is provided in person, face-to-face must also be offered. There will be a mechanism to use referrals, but those can't just be referrals where you hand someone a piece of paper. This would have to be a referral that does not require the patient to actually have to call the other provider. So it's a very warm, strong handoff. And then on my last slide here, you can see our email address for telehealth. Feel free to send in questions at any time. We're very responsive there. And I'll just say that we're at the department really committed to continuing to enable broad telehealth coverage, not just during the public health emergency, but ongoing. And we're, like I said, the policies that I mentioned today are mostly all continuing, and we will have a broad telehealth benefit across delivery systems from the department. So with that, I will turn it back over to Sarah, and thank you.
Thank you so much, Michael. So just a reminder for everyone that if you have any questions, you can feel free to drop them into the Q&A, and then we'll address them at the end of the panel presentations. So with that said, I'm going to hand it over to Dr. Stephanie Crossen from UC Davis.
Thank you. Can you all hear me?
Yes.
Great. Let me work on sharing my slides here. Let's see. And can you see the slideshow now?
Yes.
Great. Okay, well, thank you all for the opportunity to speak here today. I really appreciated hearing Dena and Michael's perspectives, and I hope I can add the physician perspective, at least one physician. I am a pediatric endocrinologist here at UC Davis. I also do research on use of telehealth and remote monitoring. So some of what I present today will be based on my research knowledge and experience, and some will be my knowledge and experience as a clinician. And first, I wanted to go briefly into background on benefits and challenges, although I think actually Dena already framed that beautifully. So I'll go quickly through some of my slides. The first question I often need to explain when I give presentations, and I don't think this audience needs it, but I'm still going to put it up here, is why would we want to use telehealth to care for children and youth who have special healthcare needs? And the answer, one of the answers, is the scarcity of pediatric subspecialists, which everyone who I've heard, speak here today as a parent and advocate has mentioned. So this graph is just for my specialty, but there are similar graphs for pretty much every pediatric subspecialty. And this shows that there are lots of counties in our state that have no pediatric endocrinologists. And even the counties that are relatively well served have a handful of these specialists per 100,000 children. And for some specialties, it's even more severe. So this is something you all know, but that's the background, and that's why we all have an interest, right? We're hoping telehealth can improve access for these patients and families while limiting the associated burdens, including transportation and cost and missed work and school time. So you all also are aware of what happened during COVID. A lot of policy changes took place during the public health emergency. And I love that Michael and all of the folks here in California are working to keep a lot of these policy changes in our state. But these changes allowed us to deliver telehealth to patients' homes, which previously was not an allowable site of care. And they also lifted restrictions on the types of video platforms that could be used. And at a federal level, during the public health emergency, there was some required payment parity so that video visits could be reimbursed similarly to in-person visits. So, with the state of emergency and those pressures, as well as the policy changes, we've all seen these kind of graphs. This is just one example. It shows pediatric telehealth visits at UC Davis. And you can see in the early 2020, there was very little use. And then the second quarter of 2020, over 6,000 pediatric video visits being done at our institution. And since then, it's tailed off a bit, but has kind of, it has stayed with some waxing and waning by season and by pandemic pressures, I would say. So Dena and Benjamin really outlined this beautifully, but I think there are multiple advantages for patients and families doing home to clinic video visits. Obviously, less missed work and school time, not needing to find childcare for additional children who can't come to the visit, which was especially hard during COVID since we were limiting visitors and extra family members at visits. The reduction in transportation costs and barriers, and then as Dena also alluded to, not needing to cancel the visit in case of illness, which is wonderful. I also have families tell me there's less waiting around. They still have to do some waiting, but the in-person visit, there's a lot of check-in time, a lot of waiting time. And a lot of families have told me they feel like they have more face time with their provider during video visits, which they appreciate. Also, as Dena alluded to, the comfort of being at home. It's a less intimidating environment than clinic. For a lot of my patients, especially teenagers, they're more open to discussing sensitive topics because they feel more in a place of power. Being in clinic, it's really, they're on our turf and it's not very comfortable, but when they can be at home and on a screen, it feels a lot safer. And then the home environment is so much more comfortable and welcoming for our neurodevelopmentally diverse patients and their siblings. If, caretakers have to bring multiple kids along to a visit, it can be so challenging to keep them happy and busy in a clinic environment. So the comfort of home is a very large advantage. And then finally, especially as a physician, I've really appreciated how video visits can lead to more inclusion. We've had additional caregivers who've never come to in-person visits just due to their own schedules, work constraints, et cetera, who have been able to join in remotely on video visits. And it's really so valuable to have them join that conversation and to talk about what they're seeing, what questions they have, what challenges they have in caring for that child. So I have loved the chance to meet really involved grandparents, working parents, parents who work, well, all parents are working, but parents who were not able to come to in-person visits due to their work schedules. And that's been a huge benefit. In addition, the chance to see someone's home environment, if they're willing to share it, and to talk about how that environment impacts the child's care has been amazingly valuable. So those are really some key advantages that we want to hold on to. And these advantages are reflected in what we see for telehealth visit attendance and satisfaction. So here you'll see telehealth visits in blue and office visits in green. And these were the rates at which people attended their scheduled visits during the first couple years of the pandemic. And you can see we had far fewer cancellations and no-shows among the telehealth visits, which was wonderful. In addition, we do a lot of post-visit surveys to better understand the patient experience. And here, telehealth visits are in orange and office visits in yellow. And you can see that the satisfaction with the visit is at the same rate or higher for the video visits compared to office visits. And that was just for our pediatric and adult endocrinologists in 2020, but there's been consistent data like this for the last few years. So Dena also alluded beautifully to some of the challenges, so I'll try to be brief on this slide, but there are challenges related to technology, right? So to do these type of home video visits, you need a video capable device and reliable internet access. And you have to be able and comfortable to use one or more digital applications, which can be quite challenging for some of our patients and families. In addition, I think it depends on the person, the patient and family and the provider, but there is a different skill set involved in making that personal connection at a distance. And that's something we're all trying to get better at, but it can be a barrier in some cases. And also it requires a quiet private space, which some people don't have at home. It's a luxury to have a room that you can go to without anyone else in it sometimes. So that's something to keep in mind as a challenge sometimes for home video visits. And then for our families who are more comfortable in non-English languages, it does require some good, reliable interpretation services remotely, which thankfully at UC Davis, we now have them join the video visit. But very early in the pandemic, this was a lot more challenging with use of speakerphone and things that were not ideal. And then for the physician, but also to keep in mind on the patient side, there are challenges in delivering complete care at times, and it varies a lot based on the day and the concern that you're addressing, but we can't conduct the same sort of physical exam over video that we can in person. And especially in my specialty, we rely a lot on blood work results, sometimes imaging. And so doing an effective video visit at home may require the patient and family to do some legwork ahead of time to get those done and get the results shared. And finally, I always want us all to keep in mind, with a video visit, you may not have closure that day. It's true for in-person as well, but something may come up that you really can't make an effective decision about without additional information or without making an in-person visit. And that's okay. That can happen for in-person care too. But I always like for us to keep that in mind and remember that care is not a one-time event. It's an ongoing process. So related to especially the first of those categories of challenges, technology, there's been a lot of data coming out during the pandemic that shows that certain groups of patients have been less likely to use telehealth, including patients with public insurance, patients of older age, from minority race or ethnicity groups, and with non-English language preferences. And that's been true across multiple different primary care and subspecialty settings and multiple areas of the country. And a lot of us think this is related to what we're now terming the digital divide, the fact that many groups have lower access to smartphones and reliable home broadband, which is shown here on the right with some data from the Pew Research Foundation. So there's a lot of concern currently about how we can close that digital divide and remove some of the barriers that are there for universal telehealth access. So after going through that background, I want to spend just a few minutes talking about the physician experience, knowing that it's not just one experience, but I can speak to my own and some of the things I hear from colleagues. And then I have just a couple slides with practical tips about how to make a video visit as successful as possible. So I get asked this question a fair amount. How does my doctor see telehealth? What do they think about it? And obviously there's not one answer, but there are two sort of concepts I want to throw out there. One is this is new for us as well. So for almost all currently practicing physicians, we did not receive any training in telehealth during our medical training. And fewer than 10% of doctors out there had any experience with telehealth before the pandemic. So this is a very new thing. It does require a new skill set, so we are all trying to get better at it. Also, there's a lot of concern among physicians that we don't have a lot of data yet to guide us, to tell us when is it effective to use telehealth, when is it appropriate. One point I often make, and I love that Michael brought up in his slides, is that telehealth is not specific care, it's a care modality. Just like having a conversation over the phone with a patient about test results is a certain skill set, and it's different than having that discussion in person. So on the one hand, as a telehealth researcher, I'm often making the point that there's going to be variety in the effectiveness of telehealth, just like in-person care has a variety of effectiveness. But on the other hand, we like to do things that we feel are evidence-based to be sure that we're really benefiting our patients. So there's a lot of concern and interest from physicians to get more data and more guidance to tell them when they should be using it. And then I will say there's some I don't know if nervousness is the right answer. This concern that if we can't do our typical physical exam or get all the data we're used to getting in person, will we be able to do a good enough job guiding care decisions? And as a high volume telehealth user, I feel a lot more comfortable about this than some of my colleagues, but I think it's a real concern, and it comes from a good place because we're trained for many years in how to make decisions based on what's in front of us. So this is the other part of it being new. And there's concern widespread about disparities in access. We really care about whether our patients have access to this, but we also don't want telehealth to go away just because there are current disparities. We see the benefits for our patients, and we really want to connect with them where and how they want to be connected. So I would say all of this is part of the current physician perspective. And the second part of that I would bring up is it's a confusing time right now. There are a lot of inconsistent, conflicting messages that physicians are receiving, both from payers and from healthcare leadership. And I love that Michael and his team at DHCS are doing a great job creating this clear documentation and clear policies. But there's a lot of variety out there. So a lot of places are seeing more restrictions in use again, where there are more state licensing restrictions going back into place where you can't provide care across state lines, some more site of care restrictions, use of telehealth for only specific diagnoses. And when these policies vary over time and between locations and between insurance plans, it becomes very confusing to sort out. Also, not all insurance plans are providing parity in reimbursement, meaning they're not all reimbursing telehealth visits at the same level as in-person visits, or they're not promising to. And that has led to a lot of concerns from hospitals. They're getting nervous about whether the same amount of physician time will lead to far less reimbursement, and that will affect their ability to keep their staff employed and all the resources that they're used to using. So this has led some hospitals to start discouraging telehealth use by their physicians. And then finally, along with the confusion about whether to continue providing telehealth, the question of whether to make telehealth more efficient on the physician side is a big one. So right now, a lot of things that the clinical staff do in the clinic when you come for a visit and the workflows that have developed there over decades have not been replicated for telehealth. And there's not that same level of support staff handling those tasks. So currently, a lot of physicians are feeling the burden of extra clerical tasks, and they're feeling a lot of burnout when they're doing all that extra work for video visits. So enough about physicians. I have like 2 more slides, and then Gabriella, I promise I'll turn it over to you. I was asked to briefly comment on what would help patients and families ensure that their video visits go smoothly. So these are some of my ideas, and I would welcome any input from the audience and the other panelists as well. First, I would say before the visit, check in about what information your provider will need at the time of the visit, whether they need you to get lab results, share any data you've collected at home, and make sure you get that done and share it to them before the visit, especially in the world of pediatric diabetes, which I work in. If we don't have that data before the visit, it's really hard to make it a productive encounter. Make sure you test out the device you'll be using and the app. So every healthcare system is different right now. Some people have you access the visit through your medical record app. Some people are using Zoom separately. So make sure you know how you're going to do it. Ideally, test it out and get technical help if you need it. And most healthcare systems will have someone to help troubleshoot it, but it goes better the day before or the week before than at the time of the visit. If you're going to need interpretation services, confirm that that's available and how you'll access it. Ideally, your provider should be looping them in for you, but it's good to know ahead of time, and that'll probably reduce your own concerns about the visit. And then make sure everyone who's going to join can join the visit. You know, anyone else who needs the link or the app who wants to join in. And then this is a note I added, make sure the child is there. So in pediatrics, a lot of what we do is help counseling with parents, but I've had parents join a video visit while their child is at a different place at school or wherever. And we then are in a sticky situation on our end because insurance won't pay for a visit if the child isn't physically present. So make sure you have your child there. If they're going to be busy, you know, doing something else, to have them at least check in, see if the provider needs to do anything specific with them during the visit. And then during the visit, make sure to join from a quiet, private place. So I have had people join from moving cars, from the state fair with a group of friends. It's really hard to have a productive conversation in those settings. Sometimes you can't avoid the construction next door or your other child who needs something urgently, that's fine, but do your best to set it up for success. And then Dena, I love that you said that you do dishes while you're waiting for the doctor to log on. That's perfect, but try to be patient if your doctor is late, especially if they're going between in-person and video encounters. Like if you converted yours at the last minute because you were ill or something, it's really challenging. Our clinics, due to check-in processes, run about 20 or more minutes later. And then the video visits, people join on time, which is wonderful. But just think, at least I'm at home, not in the clinic waiting room, and do something to stay busy and please be patient. And then this I'm recommending more and more. Have a discussion with your doctor. How often do they want to see your child in person? How often by telehealth? Map out the next 6 months, a year, you know, so that you have a shared expectation for what that looks like. I have a lot of patients who I'm comfortable seeing once a year in person, and they say, great, I want to do that in the summer. It's like, okay, that makes sense. Let's avoid missed school time. Let's book it in the summer, but we need to know ahead of time so we can make sure it happens, right? And then finally, as part of the undeveloped workflows, a lot of clinics won't have a foolproof process to get your next appointment booked after a video visit. So if you can put it on yourself and remember to call the clinic, like as soon as you finish that visit, call in and schedule your next appointment, that will help a lot. So I just want to say thank you to our amazing patients and families. You have made the sometimes rocky transition to telehealth with us, and I hope we can keep learning and making it better together. And with that, I would welcome any questions or comments at the end.
Thank you so much, Stephanie. So just a reminder to everyone to keep, dropping your questions in the Q&A section or in the chat section. We have plenty of time left for this session. We're going to go until about 12:55. So as we're listening to our final panel presentation, just remember to save up your questions and we should have plenty of time at the end for discussion. So with that, I'm going to introduce Gabriella Barbosa, who is with the Children's Partnership.
Hi, everyone. Thank you so much. It's great to be here with you all. My name is Gabriella Barbosa. I am the Managing Director of Policy at the Children's Partnership. The Children's Partnership is a statewide children's advocacy organization dedicated to advancing child health equity through public policy, research, and community engagement. Today, I'm going to be talking a little bit about a report that we wrote and released last year, as well as some data that we've been analyzing, specifically focusing on children of color who have special health care needs. I'll be providing recommendations and findings from the report, and then I'll also be talking a little bit about some resources that we've developed to help families navigate utilizing telehealth to access care for their children. So I'm going to start first with a data overview. And I didn't mention this before, but the Children's Partnership, we engage in advocacy for children, and the children that we really focus on advocating for are children from communities of color, including Latinx communities, Black communities, Asian American, Pacific Islander, and Native American and mixed communities. So who are children of color with special health care needs in our state? So this is data, statewide data, that looks specifically at children with special health care needs in California and what their racial and ethnic background is. So California's children with special health care needs are incredibly diverse, and children of color make up a significant portion of children with special health care needs. About 14% of all children in California have special health care needs. That equates to about 1.3 million children in California. And of those children, over 2 in 3 are children of color and identify as Latinx, African American, Asian American, Native American, or multiracial. So as you see from this chart, for Latinx children, there are over 600,000 Latinx children in California who have special health care needs. There are about 135,000 Native American and Pacific Islander children who have special health care needs in our state. There are 130,000 Asian American children who have special health care needs. There are 45,372 Black children in our state who have special health care needs. And there are 371,115 children who are white who have special health care needs in our state. And I'm providing this data because I think this often goes overlooked, is when you look at who children with special health care needs are, over a majority of them come from communities of color. They are not a minority population within this group. They are actually over a majority. And it's really important to think about the unique challenges that they have faced. And that's why the Children's Partnership engaged in research. Family-centered research, really focusing specifically on families from Latinx, African American, Asian American, Native American, and mixed racial and ethnic communities in California. And we really wanted to understand what their specific experiences were at the beginning of the pandemic when everything shut down and telehealth became essentially the only option for many families to continue accessing care for their children with special health care needs. We really wanted to understand the challenges that they were facing and also the benefits that they were experiencing using telehealth. So who did we talk to? In total, we recruited 85 families of color from all over California to participate in this research. Families came from Pomona, from Tulare, from San Bernardino, and from Riverside. Families self-identified themselves and their children as Latinx, African American, Native American, or Asian American. And over half of the families that we talked to were monolingual Spanish speakers. Children from almost all grades were represented, including preschool and all the way through adult school. Sorry, there's a little bit of noise in the background, so sorry if you all can hear that. Children from the families that we interviewed also had a range of unique healthcare needs that included physical, developmental, mental and complex health conditions. And the learnings in our report really reflect the voices and experiences of these families, again, families of color who have children with special health care needs that were captured through listening sessions that we held with them and an online survey. So we have 5 broad categories of learnings that we heard from families. The first is telehealth really did help keep children of color with special health care needs connected to health services during the pandemic. Families talked to us about how the shutdowns and rapid shift to telehealth led to their children losing access to services, some for significant amounts of time that were never recuperated. Some services were offered through telehealth, while others continued to be provided in person, and this really confused and frustrated families. When it came to the types of services and doctors that families were able to see and access utilizing telehealth during the pandemic, parents reported that their children had telehealth visits with specialty providers like gastroenterologists, endocrinologists, neurologists, and geneticists. Telehealth was also used for counseling and speech therapy, as well as physical and occupational therapy. Our second learning was that telehealth helped families address some challenges children of color with special health care needs typically face when accessing care. Telehealth made it easier for families to access care by addressing issues like lack of transportation, long wait times for appointments, and lack of childcare. Families talked to us about how barriers related to transportation were greatly eased, saving families time and stress. There were a number of families who talked to us about having to take multiple buses to get to their telehealth appointments. To get to their in-person doctor appointments, and how utilizing telehealth relieved all of that stress that they would have to face when they did that prior to the pandemic. Families also talked to us about how telehealth was useful for children who experienced anxiety when they traveled and found it challenging to interact with other people, for example, on public transportation. And these children felt more comfortable and safer in a home environment. Families talked to us about how appointments for telehealth for their children were more easily scheduled and timelier. And they also talked about how telehealth was more accommodating to a family's specific needs around childcare. And that's specifically, they talked to us about how when they had in-person appointments with their providers, they often were not allowed to bring in the siblings of their children, and how that caused them huge barriers to being able to go in person. And with telehealth, they could have their siblings in the same home, and the family didn't have to worry about getting childcare for them. Our third learning was that families indicated strong interest in the option of having telehealth appointments for their children, while at the same time noting that telehealth did not adequately address all of the special health care needs that their children had. In the survey, I mentioned that families took nearly 1 in 2 parents, 46% expressed that there were situations where they actually preferred in-person health appointments and wanted to have that choice. Families also noted that some of their children did not respond well to the use of technology to access care. They noted how children respond differently to technology as a result of their condition. For example, with certain conditions, telehealth, accessing services through telehealth could cause confusion, delayed progress, or harm. For example, one mother spoke about the difficulty she faces utilizing telehealth for a child with epilepsy, whose episodes are triggered by too much light. Another mother spoke about how her child with speech development issues really struggled with telehealth, noting that the doctor could not clearly see her daughter's mouth movements to determine whether she was accurately using her muscles, and that her daughter similarly could not understand her doctor utilizing telehealth. Our fourth learning is that families really still, even though there were many benefits to utilizing telehealth, families continue to face unique systemic challenges that really limited their ability to access care for their children using telehealth, including digital, educational, language, and cultural barriers. And I wanted to go more deeper into this specific finding in particular. As I mentioned, families faced digital challenges to utilizing telehealth. That included the lack of Wi-Fi or lack of devices, or having to share devices among multiple family members. Families also talked to us about how they weren't really explained what telehealth was or how to use it, or what the different apps that they were supposed to download on their phone. They really didn't understand it. there was insufficient information, education, and tools provided to families around accessing healthcare services utilizing telehealth. The third barrier that families faced, and this came up across nearly all of the families who were non-English speakers, families experienced major language barriers in accessing care and services for their children using telehealth. On our survey, more than 60% of parents talked about how they experienced some barrier related to accessing translation services utilizing telehealth. When it came to those language barriers, there were a number of families who talked to us about how they would have to ask their other children, other family members, or even neighbors to translate for them in order to really access health appointments utilizing telehealth, because even though they asked for an interpreter, they were never given one. Some families who were told that they would be able to access an interpreter had to wait a very long time to access the telehealth appointment in order to wait for the interpreter, and just decided to take a closer appointment and not utilize an interpreter because of that. For families who had an interpreter during the telehealth visit, parents reported mixed results in how well interpretation worked during a telehealth visit compared to an in-person visit. Families also talked about how when they did have an interpreter, they didn't have extra time with their provider. So even though there was an extra person that was speaking, it was the same amount of time that they were given, and how they felt extremely rushed. There was one family member who gave us this incredible, brilliant recommendation about how there should be a policy that non-English speakers be given more time for telehealth appointments because of the interpreter being there present with them. The other barrier that families talked about was the lack of providers and doctors who really reflect the identities and experiences of families of color with children who have special healthcare needs. Children of color special healthcare needs, including those from immigrant communities, face barriers accessing providers that look like them and speak like them. Providers who meaningfully understand or reflect families' racial, ethnic, cultural, and linguistic identities, which continued in a virtual environment. 56% of families reported experiencing cultural barriers using telehealth. Parents really expressed a need for providers to have a greater understanding specifically of the immigrant experience and its impact on access to care and services. I also wanted to highlight some quotes that we got from families, just to give everybody a sense what we heard exactly and specifically from families in their own voices, highlighting those challenges I mentioned earlier. One mother from Tulare talked about, she said, "I live in a zone where Wi-Fi fails a lot, and the school has given us internet devices that are not that great. My daughter is in a medical program and she struggles a lot with hotspots. I do not have another source of internet because the companies tell me that they are not available in my location." Another mother who has a son with a speech delay said, "It was difficult because I wasn't taught how to use computers or technology. My kids helped me, but it was a challenge. My screen would freeze, my internet would drop because there were so many people using internet at the same time in my household." Another mother said, "CCS, California Children's Services, has never provided me a report in Spanish in 25 years. My child's doctors will take notes with codes, and it's sometimes difficult to understand the next steps. Every health or social service professional speaks a lot in code, and it's not easy for parents to understand." Another mother of a young daughter with Down syndrome said, "I think non-English speakers should be given more time for telehealth appointments. I have translated for my mom during telehealth appointments with my sibling who has a special need at least 7 times. The doctor has never once asked my mom if she needs translation services. There's an expectation that me or my siblings will translate for my mom." Another mother said, "Families need access to interpreters. It takes a long time to get a telehealth appointment when I request Spanish interpretation, longer than if I don't request it." And then finally, the last quote I want to share was from a mother of a teen daughter with behavioral health needs. She said, "I don't speak English, and when I tell the interpreter what to ask the doctor never responds to my question. And I don't know if it's because I'm not explaining myself well, or if the interpreter is not translating what I'm asking. So I wanted to share those quotes because I think they really give life to these challenges that we heard that families are facing. These are real challenges that that still exist. So now I actually wanted to hear from the families who are with us in this breakout group now. And if the first poll can be launched, please. All right, can everybody see this poll? Okay. So this first poll is, have you or the families you serve ever experienced challenges related to Wi-Fi or internet connection? En español, usted o las familias a las que sirve han tenido desafíos relacionados con la conexión Wi-Fi. It looks like people are responding so far. So far, it looks like we have 80% of respondents who have said that either they or the families that they serve have experienced challenges related to Wi-Fi connection. And this really mirrors what we heard from families as well. And I'll let more families respond to this poll and close it in just a second. Okay, I just ended the poll. So the results show that 91%, 91, wow. The vast majority of people who are with us in this room, Zoom room right now, have experienced challenges related to Wi-Fi connection. That will have a huge impact on families' ability to access telehealth. And I'm sharing the results right now. Apologies, I didn't share them earlier. Okay, let's go on to the next poll. If the poll number 2 can be launched, please. Can the second poll be launched, please?
Sorry, give me 1 second. I'm working on it.
No problem, Caitlin. I'm sorry, I can't see the screen, so.
Yeah, and I think all the questions went up at one time. Sorry about that, Gabriella.
Oh, okay.
So all 4 questions were posted at the same time. We can share those results if you scroll down.
So should we launch it again?
So if we launch it again, we might lose the answers from the first round.
Okay, so sorry, I only saw the first one, so I can go ahead and go into the next one. So for the other poll, we had asked if families have ever experienced challenges due to not having devices that connect to the internet. And on this one, 70% of you all share that you have experienced challenges due to not having devices that connect to the internet. Our third question was, have you or the families you serve ever experienced barriers accessing an interpreter in healthcare? 67% of you all said that yes, either you or the families that you serve have experienced barriers accessing an interpreter in healthcare. And then our last question was, have you or the families you serve experienced barriers accessing important health documents in a language that you understand, like reports or after visit summaries when you go and visit your child's doctor? And 67 respondents said yes, that they have experienced barriers. Thank you all for taking those polls with me. I'm gonna stop sharing these now. So I really just wanted to hear from you all and see if what we heard from the families that we listened to in this report mirrored the experiences that you all have, and they very much do. And so it's really important to highlight that these challenges still very much exist and need to be addressed at a systemic level. So that's where we come to our recommendations. So our report also laid out 7 recommendations that we felt and that we also heard from families would help address some of these challenges that they were facing. I'm only going to go into a couple of them right now. So our first one was that we are advocating for, and we really are trying to push the Department of Healthcare Services to clarify that community health workers and promotores services that support members to access telehealth are considered covered services. And this relates to the physician burnout that Stephanie just talked about, that clerical work, about the education and outreach that families need to have in order to really understand what telehealth is or how to use it. And Michael talked about how community health worker services that are provided through telehealth are covered, but this is slightly different. This is actually enabling community health workers to help families navigate telehealth, to do outreach with families around telehealth, to educate families around telehealth, and really work with physicians so that there isn't a physician burnout when they have to engage in those activities, and make sure that families are receiving the navigation, outreach, and education services that they need to really utilize telehealth to access healthcare and services for their children. Our next recommendation that I wanted to highlight really focus on language access, because this is one of the biggest barriers and challenges that we heard families facing. And again, non-English speaking families facing. Our first is that telehealth appointments that include an interpreter should be scheduled for longer than if the same appointment were scheduled without a translator. And again, that recommendation came straight from a mother. Our second recommendation from DHCS is that DHCS should clarify that Medi-Cal managed care plans have the responsibility to provide all telehealth related documentation in languages when requested by members. And our third is that DHCS should clarify that members have the right to have their patient records and reports translated and available to access both in paper and online. I'm going to skip through these slides because Michael already covered most of these. So now I will share a couple of resources that the Children's Partnership has developed in order to help families understand and navigate telehealth and access healthcare services utilizing telehealth. And I'll also share these in a follow-up email to you all and all the attendees. You'll all have these as well. The first is an FAQ, a fact sheet that we created called Telehealth and Children FAQ. And this is really in a document that is meant to just, in very plain language, explain what telehealth is and how families can use it and how families can request telehealth appointments. It also talks about how families have the right to an interpreter in telehealth. Many families don't realize this and don't know this. You all have a right to an interpreter when you access healthcare services utilizing telehealth. And it's important that you understand and know that right. And this fact sheet really highlights that right, as well as other important things that families should know when it comes to utilizing telehealth. Another resource I wanted to share is it's really important that families know what to do if they're not receiving translation services or interpretation services. A number of the families that we talked to, when we asked them, okay, if you weren't able to access an interpreter or translated documents, what happened next? And the family said, nothing. I didn't know what to do. They didn't realize that they had this right. So that's why I'm sharing this resource. This resource is from the Department of Healthcare Services. It specifically talks about families' rights around language access and what to do if your rights are being violated. You can submit complaints, and you can also call a phone number and email in order to make sure that you're getting those services. If you even just need help or have questions about interpretation services, there's also a phone number that you can call directly with the Office of Civil Rights in the Department of Healthcare Services that you can ask about, what are my rights when it comes to getting things translated, getting an interpreter, so that you can really understand what they are. And again, I will share this resource as well in the chat and also in an email. And then the third resource I wanted to share is actually a federal program that families can access if they have a certain income level that really helps families get connected to high-speed broadband. And again, this resource is really trying to address the digital challenges that we heard families were facing when it came to utilizing telehealth, the lack of high-speed broadband and the lack of devices as well. And that's it. And I'm happy to answer questions. Also happy to share my information if anyone wants to talk more about any of what I spoke about or any of the resources that I shared.
Thank you so much, Gabriella, and to all of the panelists. Not seeing any questions in the chat, but I'm also just scrolling through just to make sure. So I'm not seeing questions in the chat or Q&A. So if you do have questions, this is a great time to put them in there, or I think people can come off mute and ask questions as well. Maybe I can't see what functionality is available to you all, so I'm not totally sure about that. But please feel free to share any comments and questions that you have. Thank you so much to our amazing panelists. This was just an incredible wealth of information from all different perspectives. I'll give it a couple more minutes. I know people sometimes need a little bit of time to process and think of questions. And then if we don't see any questions popping up, I know no one is going to complain about having a few extra minutes before our closing keynote at 1, but we'll just give it a couple more minutes. Okay, everyone. Well, last chance for questions. Thank you so much, Dena, Michael, Stephanie, and Gabriella. Your presentations were incredible. You packed a lot of information into really concise and short amount of time, so it's much appreciated. And so the closing plenary begins at 1, so everyone gets a little break to go get some food or some fresh air. And we'll see you all back at 1. Thank you so much, everyone, for joining.
Thank you, everyone. You want to say goodbye?